Most women assume they'll know clearly when something is seriously wrong with their brain, a dramatic symptom, something unmistakable. For a brain aneurysm, that assumption is mostly right, but not entirely right. There are signs that can appear weeks or months before anything dramatic happens. They look like a migraine, a stiff neck, tired eyes, a brief moment of confusion. Here are 10 of them, and number 7 is the one that gets dismissed most consistently by the person experiencing it and by the doctor they mention it to. A brain aneurysm is a bulge or weak spot in the wall of a blood vessel in the brain. Most never rupture. Most are discovered incidentally during a scan for something else and simply monitored. The vast majority of people who have one live their entire lives without knowing it was there. But when an aneurysm grows larger or begins to press on surrounding structures, it can produce symptoms, and those symptoms are often vague enough that they get filed under stress, or aging, or migraine, for a long time before anyone connects them to anything structural. That's what this list is about. Not the dramatic rupture, which is unmistakable and requires emergency care immediately. The quieter version. The signs that show up earlier, when there's still a window to do something. Research published in Stroke found that women have approximately 1.6 times the rate of intracranial aneurysm compared to men, and that this difference becomes most pronounced after menopause. The reason is related to estrogen. Among its many roles, estrogen supports the structural integrity of arterial walls throughout the body. After menopause, estrogen levels drop significantly, and the arterial walls, including those in the brain, lose some of that structural support. This is not a guarantee of anything. The majority of women are completely unaffected. But it explains why this topic is specifically relevant to women over 60 in a way that a general brain health video is not. Women in this age group are also statistically more likely to attribute neurological symptoms to stress, sleep, or hormonal changes, and more likely to delay seeking care for them. Both of those tendencies matter when it comes to this list. One important distinction before we go through the signs. Sign number 1 on this list is a medical emergency. If it describes something that happened to you, even briefly, even if it passed, this is the one that requires calling emergency services immediately, not watching more of this video first. Sign 1. A headache that arrived in seconds and peaked instantly. This is called a thunderclap headache, and it is different from any headache most people have ever experienced. It reaches maximum intensity within 60 seconds, sometimes within seconds, and is often described as the worst headache of my life. A sudden explosion, something being hit in the back of the head. It may be accompanied by nausea, sensitivity to light, or brief loss of consciousness. This specific pattern, sudden onset, immediate peak, maximal severity, is the classic presentation of subarachnoid hemorrhage, which is what happens when an aneurysm ruptures. Even if it passes on its own, even if you feel better an hour later, a thunderclap headache requires emergency evaluation immediately. Do not drive yourself. Do not wait until morning. This is the one that does not get a watch and wait response. Sign 2. A recurring headache that always starts in the same specific spot. Not a general headache that moves around, not a tension headache across the forehead. A headache that comes back repeatedly and consistently begins in the same location, often at the back of the head, behind one eye, or at the base of the skull. This pattern can represent what's called a sentinel headache, a minor leak from an aneurysm that's small enough to self-seal, but large enough to cause brief irritation of the surrounding tissue. Research published in Lancet Neurology found that a significant proportion of patients who experienced a major subarachnoid hemorrhage reported recurring headaches in the weeks preceding it that they had not investigated. Sign 3. Pain specifically behind or above one eye. Not a general eye, strain headache from screens. A pain that is consistently localized to one eye, specifically behind it or directly above it, that arrives without an obvious cause and comes and goes. This location is particularly relevant because several of the blood vessels most commonly associated with aneurysm formation run through or adjacent to the structures immediately behind and above the eye socket. Pain in this location, especially if it's new and one-sided, is worth naming specifically at a doctor's appointment rather than filing under headaches generally. Sign 4. Brief episodes of double or blurred vision. Vision that briefly doubles, blurs, or dims and then returns to normal, especially if it's one-sided or affects a specific part of the visual field. This happens because some aneurysms form in locations where their expansion affects the optic nerve or the blood supply to the visual pathway. Episodes that come and go are often attributed to fatigue, dry eyes, or the need for a new prescription. When they occur alongside any other sign on this list, the combination is worth a specific conversation with a doctor framed as a cluster of related symptoms rather than separate complaints. Sign 5. Neck stiffness that wasn't caused by sleeping wrong or physical strain. A stiff or painful neck that you can't explain by what you did physically, particularly one that came on gradually without any obvious trigger. Minor subarachnoid bleeding can cause meningeal irritation, which produces neck stiffness as one of its early signs. Most people assume their neck pain has a physical cause, which it usually does, but neck stiffness in the absence of a physical explanation, especially alongside a headache or any other sign on this list, is worth mentioning specifically. Sign 6. New or suddenly worsening sensitivity to light. Photophobia that's new, or noticeably worse than it used to be, and that isn't explained by an eye condition you already know about. This is another sign of meningeal irritation, where even a small amount of blood or pressure in the space surrounding the brain increases sensitivity to light input. Most people attribute worsening light sensitivity to getting older, screen use, or the need for a different glasses prescription. When it's new and doesn't have a clear explanation, and especially when it comes with headaches or any other sign here, it's worth naming. Sign 7. A drooping eyelid, or one pupil noticeably larger than the other. Here's the one that gets missed most consistently, including in medical settings. One eyelid that has gradually begun to droop, not dramatically enough that anyone else necessarily notices right away, but enough that you see it in photos or in the mirror. Or one pupil that looks measurably larger than the other when you compare them in good lighting. This specific combination, drooping eyelid and unequal pupils, is called oculomotor nerve palsy, and one of its documented causes is an aneurysm pressing directly on the oculomotor nerve, which is cranial nerve 3. This nerve controls the muscle that lifts the eyelid and the muscle that constricts the pupil. When an aneurysm in a specific location, most commonly where the posterior communicating artery meets the internal carotid artery, grows large enough to compress this nerve, the eyelid droops, and the pupil on that side enlarges. Research published in neurosurgery identifies oculomotor nerve palsy as a presenting symptom in a meaningful proportion of posterior communicating artery aneurysms, and emphasizes that it frequently gets attributed to diabetic nerve damage, aging, or a cosmetic eyelid issue before the vascular origin is considered. Check your pupils in a well-lit mirror right now. They should be equal in size and both responsive to light. A new difference in size between the two, especially on the same side as any headache or eye pain, is the specific finding to bring to a doctor this week. Sign 8. Numbness or tingling on one side of the face that wasn't there before. Facial numbness or tingling that is consistently one-sided and new, not the brief tingling that comes from sleeping on your arm. A persistent or recurring change in sensation on one side of the face, around the cheek, the temple, or the jaw area. The facial nerve and the trigeminal nerve, which supply sensation to the face, can be affected by vascular pressure from nearby aneurysms depending on the location. One-sided facial changes that are new and unexplained are worth a specific mention in the context of this list, rather than being described generally as tingling or numbness without the one-sided qualifier. Sign 9. A brief episode where words wouldn't come out right, or thinking felt suddenly foggy. An episode, perhaps 10 or 20 minutes, perhaps shorter, where the right word wouldn't come, or where thinking felt unusually clouded, and then it resolved and everything felt normal again. Most people attribute these moments to tiredness, stress, or getting older, which they usually are. But a brief episode of this type that is new, that is more pronounced than ordinary tiredness, and that occurred alongside a headache or any other sign on this list, is worth describing specifically to a doctor, including when it happened, how long it lasted, and what else was occurring at the time. Sign 10. A brief episode of confusion or disorientation that resolved on its own. A short window, perhaps a few minutes, of genuine confusion about where you were, what you were doing, or what was happening around you, followed by full return to normal. This pattern, known as a transient episode of neurological dysfunction, can represent a minor and self-resolving event from a small bleed or temporary pressure change. It is easy to explain away as a dizzy spell or a strange moment of dissociation and never mention to anyone. When it is new, when it is more pronounced than anything experienced before, and when it occurred alongside other signs on this list, it belongs in a doctor's appointment this week, framed as a transient neurological episode with approximate timing and duration. What to do if you recognized more than two? Two or more signs on this list, occurring in a pattern rather than as isolated one-off events, warrants a doctor's appointment this week with a specific request. The test to ask for is an MRA of the brain, magnetic resonance angiography, or a CTA, computed tomography angiography. Both can image the blood vessels of the brain directly and detect an aneurysm that would be invisible on a standard brain MRI or CT scan. The words to use are, "I have a cluster of neurological symptoms I want evaluated for a vascular cause, and I would like an MRA or CTA of the brain." That specific request, using those specific words, is significantly more likely to result in the appropriate imaging than describing individual symptoms separately without framing them together. Most people who pursue this imaging will find nothing of concern. That is both the most common and the best outcome. The purpose of this video is to make sure the people for whom something is found actually sought the imaging, rather than waiting for the symptom that no longer allows waiting. Write in the comments whether you recognized any of these, particularly 7, and whether it was one you'd ever connected to anything vascular before, and your age and where you're watching from. Women over 60 are exactly the audience this video was made for, and the comments tell me how far it's reaching.